welcome our respected speaker for the day, Dr. Sudhakar Rao Vala, Senior Consultant Cardiologist of Krishna Institute of Medical Science, Hyderabad. I am sure this unique platform where evidence meets experience will help all to enrich their knowledge during these COVID times. Being the host of this program, let me brief some important aspect of this program. All participants to please keep their mics muted except the panelists. This is to avoid background noise. If you have any question to ask, please use the chat option and send it to us, and we shall present to the panel your question to the panel member for answering. You can send your question anytime during the discussion. So once again, I welcome you all and request our respected speaker, Dr. Rao, to start proceeding further. Dr. Dayasagar.
Thank you, Shantanu. Thank you for inviting me to give a talk on cardiac symptoms, evaluation, and the pathophysiological basis of these cardiac symptoms. This is a basic understanding of these things will help you to evaluate the cardiac patients better. Can I have the next slide, please? Next slide, please. Yeah, okay. What are symptoms? Symptoms are systematic collection of information as told by the patient. We should allow the patient to speak freely, uninterruptedly, either by the attendant or by the doctor, so that he can express the symptoms or he can express his problems freely and untainted by any other information from the bystanders or from the attenders. This is more so important because the full understanding or full expression may be slightly different from what the attendant can perceive of the symptom of the patient. In patients who have got a cognitive impairment, the information given by the attendant may be equally useful, just as a bystander information in patients with syncope is extremely useful. Can I have the next slide? Okay, so what is the purpose of eliciting these symptoms and interpretation of the symptoms? First, these symptoms will allow us to know whether the patient has got any cardiac disease or the presence of the disease. And knowing the severity of the symptoms, we can also know the severity of the disease. And finally, we can also know the type of diseases depending upon various factors, including the age at onset. For example, the patient develops symptoms at the age of 6 years. It is very likely that the disease is mostly congenital rather than acquired, just as the occurrence of a disease in a 60-year-old man is more in favor of a vascular disease rather than any other congenital heart defect. It will also tell us whether it is a congenital disease or acquired disease, especially if there is a history of coexisting history of rheumatic fever or whatever it is, which might help us in knowing what is the nature of the disease. Progression of the symptoms over a period of time during the course of this disease will tell us whether the disease is progressing slowly or faster. If it is progressing is rapid, then the differential diagnosis will be totally different. And we can also try to get from the history whether this rapid downhill course is caused by cardiac factors or non-cardiac factors like infection, anemia, etc. Can I have the next slide? Finally, symptom evaluations also gives us some idea about the response to therapy, be it a drug therapy or interventional therapy like an angioplasty or a valvuloplasty, or the effect of surgery on the symptoms. You need to understand, you need to evaluate, you need to ask the patient, after the intervention or after the drug therapy, what happened to the symptoms? Is there near total, what do you call, resolution of symptoms? Or is there any partial resolution of symptoms? Or there is no resolution of symptoms, but on the contrary, there may be even worsening of the symptoms. So that will also tell us what has been the response of the disease to the drug therapy or interventions. Can I have the next slide? Symptom elicitation from the patient requires a lot of skill and tact. Certainly, practicing of eliciting the history improves your ability to get the right information from the patient. And as I said earlier, patient should be allowed to speak uninterruptedly, and the answer should be in an open end, in the sense that do not interrupt the patient's flow of the talk or symptoms, either by the doctor or by the attendant. So this is history taking, especially eliciting the symptoms, requires a lot of experience and a lot of skill, and it should be focused evaluation of the symptoms. Can I have the next slide? Next slide, please. Okay. So what are the cardiovascular symptoms that are suggestive of a cardiac disease or a vascular disease? Please go back to the previous slide. Yeah, okay. So the symptoms: chest pain, palpitations, syncope and pre-syncope, edema of the dependent areas, and claudication of the limbs, be it lower limbs or upper limbs, and presence of cyanosis, which may be noticed by the patients or their attendants. It is important to remember that these symptoms, sometimes the cardiovascular disease will have symptoms referred to other systems, like a history of dysphagia or a hoarseness of the voice or a neurodeficit in patients who have developed a cerebral embolism consequent to an atrial fibrillation in a valvular heart disease. So you should also elicit not only the cardiovascular symptom, but also symptoms referable to other systems. Can I have the next slide? Okay, chest pain is the most common symptoms, especially in these times. In the last decade or so, chest pain is the most presenting cardiovascular symptoms nowadays. Quite frequent, and it is important that you should evaluate the chest pain symptom in great detail. Don't be very casual about interpretation of chest pain as anginal or non-anginal. It is more often than not, it is not the pain, but it is a discomfort over the chest, or more specifically, uneasiness within the chest. This uneasiness can be location may be substernal or left pectoral, or very rarely right pectoral, and sometimes even in the epigastrium. So once you know the location, you should also ask what is the duration of the discomfort. Each one component of these chest pain syndromes has got a lot of meaning and a lot of clinical relevance. Normally, an anginal pain does not last for more than 10 to 15 minutes. If it lasts for hours or days, it is less likely to be a that is ischemic pain rather than any other pain. There are other pains of the cardiovascular system that really last for a longer period of time, like pericarditis pain. By and large, an ischemic cardiac pain generally does not last more than 10 to 15 minutes. The pain often not only present in the substernal region, but does radiate to various regions, up to the lower jaw or up to the epigastrium, and certainly to the left arm in most of the situations, and occasionally to both arms, and very rarely it can radiate into the interscapular region. But what is important with this discomfort is it is consistently precipitated by physical effort and consistently relieved either by taking rest or by taking sublingual nitrates. So the precipitating factors and relieving factors should be evaluated. Precipitating factors need not necessarily be physical effort. It can also be precipitated by emotional stress. It can also be precipitated by overeating, full stomach, and it can also be precipitated by walking in a cold weather, especially in a chilly winter. More so in the West rather than in our country. Less so in South India, more so in North India. So basically, you need to know the relationship of the discomfort of the chest in relation to effort, emotion, eating, and environment. And relieving factors, rest, and also sublingual nitrate. It is important to remember that ischemic chest pain becomes worse when you lie down flat. It gets relieved when you sit up at the edge of the bed and then hang your legs at the edge of the bed. The idea, I'll explain to you all these things, why this happens. Can I have the next slide? It is very unusual that all patients will give you the classical description of substernal discomfort precipitated by effort, relieved by rest. So Forrester and Diamond have devised these three characteristics, like where is the location and character of the discomfort, precipitating factors, and relieving factors. If all three factors are present, it is called a typical angina. If only 2 out of 3 are present, we say it is atypical chest pain. If only 1 is present, we say it's a non-cardiac chest pain. This is very relevant when we come back to the history again in the next few slides. Can I have the next slide? Okay, so for you to understand why the pain becomes more on effort and relieved by rest, we need to understand that what are the major determinants of myocardial oxygen demands, major determinants. So for the 4 major determinants of myocardial oxygen demands are, one is heart rate, second one is the blood pressure, more so the systolic blood pressure. Third one is the contractility, fourth one is the wall stress. So if there is any condition that increases the heart rate, the chance of precipitating an ischemic episode is high because heart requires more blood to do extra work. And in the presence of a obstructive coronary artery disease, this cannot be achieved. So if any of the 4 or in various combination occur in a given situation, that is either increase in the heart rate or increase in blood pressure or increase in contractility or an increase in wall stress. What do you mean by wall stress? Is the stress on the wall of the ventricle, which is related to cavity size. That is, that the larger the cavity size, the greater is the stress on the left ventricular wall. And the greater the thickness of the left ventricular wall, the lesser will be the wall stress. So cavity size is directly proportional to the wall stress, and wall thickness is inversely proportional to the wall stress. So what happens when you sit down with your legs hanging at the edge of the bed? There is pooling of the blood in the legs, and then there will be less venous return to the heart. So the cavity size decreases, so the wall stress decreases, so the need or the demand for oxygen will become less. On the contrary, if you force the patient to lie down flat on the bed, his pain will not be relieved. And if you really take the history properly, most of the patients will say that their discomfort is relieved by sitting up in the bed. So don't force them to lie down in the bed in the sense saying that you should take rest and lie down flat. Lying down flat certainly will exacerbate the ischemic chest pain. That's one of the clues that somebody getting up in the middle of the night and then says after sitting up for about 15 minutes, his pain is relieved. Consider the possibility of a coronary ischemic pain. Can I have the next slide, please? Okay, not only you should diagnose the presence or suspect coronary artery disease based on the symptoms and its characteristics, but you should also try to evaluate whether the type of angina is it stable angina or what we call in the new terminology a chronic coronary artery disease, or is it acute coronary syndrome. So how do we decide clinically based on the symptoms? So if the patient has been having chest discomfort and you have made a diagnosis, possibly coronary artery disease and anginal pain, you need to ask, what is the frequency of chest pain? What is the duration of discomfort? And what is the threshold of angina? When we say this threshold of angina, we mean how much distance he was able to walk without getting any chest discomfort. If there are no changes in the last 1 month in the frequency of the chest pain or the duration of discomfort, or no change in the threshold, then we say probably it is a chronic coronary artery disease and not an acute coronary syndrome. Rest angina is a very important symptom, and it almost always indicates a very severe disease calling for urgent investigations and therapy. Nocturnal angina, meaning that the patient gets pain only during the night time. He gets up and then sits for a while, and then the pain is relieved and then goes back to sleep. Nocturnal angina is quite often a sign of an incipient left heart failure, left ventricular failure. Nocturnal angina is also a symptom of coronary artery disease, especially in patients with aortic regurgitation. What happens is that when you sleep, your heart rate comes down, so the duration of diastole increases. Consequently, that the magnitude of aortic regurgitation also increases, because aortic regurgitation is a diastolic event, and the longer the diastole, the longer the duration of regurgitation, so the magnitude of regurgitation increases. Consequently, that the need for myocardial oxygen increases because left ventricle go on stretching. Postprandial angina is also a very serious symptom, and you specifically ask, postprandial angina is almost synonymous with a incipient triple vessel disease. They may not get the pain on walking on empty stomach, but they will get pain after a meal, even however light it is. He says, I'm able to walk about 2 kilometers on empty stomach early in the morning, 6 o'clock. But in the evening, when I go for a walk at 4 p.m. after having a snack and a tea, I can't even walk half a kilometer. This is one of the manifestations that postprandial angina per se, in the sense, full stomach per se can precipitate angina, but full stomach food or after the meal, also it does reduce the threshold of angina. Basically, because after food, that there is an inappropriately higher heart rate, inappropriately higher systolic blood pressure for the same given amount of exercise. That is the reason why soon after a meal, their angina is a bit more frequent. Finally, we have a second wind phenomena. That means his patient says at the beginning, he has some discomfort after walking about 300, 500 yards. And afterwards, he continues to walk, and then there is no discomfort at all. This is not common, but it does happen. One of the theories to explain this kind of a thing is there is obstructive coronary artery disease with some collaterals feeding the obstructed coronary artery. These collaterals are not sufficient to maintain or to supply enough of oxygen at the resting period. But when the patient starts to walk, the collaterals start to dilate. Then it does increase the coronary blood flow to the myocardium. So initially, there will be angina, but continued walking results in probable dilatation of the collateral vessels feeding the obstructed coronary artery, and that will overcome the increased demands consequent to the exercise. This concept of variable threshold angina has to be understood. What do we mean by variable threshold angina? That means some days he says he's able to walk 2 kilometers early in the morning. Other days he says he cannot walk about not even half a kilometer. So whenever a patient gives a variable threshold angina, you have to suspect there is an additional vasospastic coronary artery disease. There is not only fixed obstruction to the coronary artery, but there is also a superadded coronary artery spasm, whatever may be the reason for spasm. So variable threshold angina, you have to ask the patient specifically, otherwise he will not be able to volunteer. He will not be able to understand the significance of the variable threshold angina, because this has got some therapeutic importance. If the angina has got a variable threshold, you should not only give anti-anginal drugs, which are beta blockers and nitrates and other things, Also, you have to give drugs which will prevent coronary artery spasm, including calcium channel blockers, in addition to beta blockers. So this is historical one. So once you know the stable angina or acute coronary syndrome, you should also note down what is the severity, what is the number of episodes in a day or in a week. And one of the indirect ways of evaluating the severity of angina is to ask the patient how many sublingual nitrates he has used per day and whether the number of tablets being used, is it the same, is it increasing or is it decreasing? That will give us whether the angina has been stable or it is becoming an acute coronary syndrome. So this evaluation, not only you should be able to make a diagnosis of angina, but you should also make the diagnosis whether it is a chronic coronary artery disease or a stable angina, or whether the patient is entering into the acute coronary phase. Can I have the next slide, please? Okay, so Canadian Cardiovascular Society has summarized, put all these things into one category, what they call classification of angina. And there, what they have used is, are the symptoms interfering with your ordinary physical activity, ordinary daily physical activity? If they're not interfering, then that's fine, that is class 1. On the contrary, the patient is symptomatic even at rest and is unable to do any activities, that becomes class 4. Class 2 is, there's a slight limitation, occasional limitation. Whenever he tries to do rapid work or walk against a gradient, or he gets emotionally disturbed. Class 3 is, there's a marked limitation of activity of angina, and minimal activity can be done. But there is no angina at rest. So basically, you need to ask, what are the, is it interfering with his daily activities or not interfering with daily activities? If it is not interfering with your daily physical activities, it is a very mild angina, what we call a class 1 Canadian Cardiovascular Society angina. So you should make a diagnosis of angina. You should also classify what is the severity of angina based on Canadian Cardiovascular Society severity of angina. Can I have the next slide? Next slide, please. Yeah, okay. Now, while we are talking about the chest pain, there's one more condition which is equally serious, probably more serious than a coronary artery disease, is a dissecting aneurysm, wherein there is separation of the intima from the media by the blood that is occupying it. There is a tear in the intima of the aorta, and then it goes on dissecting it, separating the intima from the media. This is what we call dissection aneurysm of aorta. That also causes chest discomfort. It can affect the ascending aorta. When it does, you do get an anterior chest pain. But more often than not, it is a dissection of the descending thoracic aorta beyond the left subclavian artery. That's far more frequent. In those conditions, that the chest discomfort is mostly in the interscapular region. Sometimes this pain can also extend to the abdominal region, because as the dissection progresses from the descending thoracic to the abdominal aorta, the pain also migrates. But more important than the location of the discomfort is that the chest pain is severe at the onset, severe stabbing, piercing, severe enough, the patient says, I can't bear it, I couldn't bear it. So that is the kind of pain, severe at onset, and then becomes less and then persists for hours to days. In contrast, the anginal pain is very mild. Initially, you feel, what is something? We are not feeling normal. Then gradually, it keeps on building up. It becomes more and more severe. So it is a crescendo type of chest pain in patients with angina. Whereas in a dissecting aneurysm, the pain is severe or maximal at the onset, and then comes down and then stays for hours to days. In contrast, the pain in angina is mild to start with, increases, and usually lasts not more than 15 to 20 minutes, unless the patient has gone into develop an acute ST elevation myocardial infarction. We should suspect dissecting aneurysm whenever the patient has got an uncontrolled hypertension. That's the biggest risk factor for development of dissecting aneurysm. But don't forget that even non-hypertensives can also get dissecting aneurysm. Especially dissecting aneurysm is missed out in the youngsters, because we often feel that this hypertension is beyond the age of 35, 40, so we don't even consider it. But in patients having Marfan syndrome or Ehlers-Danlos syndrome with connective tissue disorders, it can have dissecting aneurysm without the patient having any hypertension. Same thing applies in the postpartum period. Young female delivered, 1 week after that, the patient says she's having severe, unbearable pain in the interscapular region. Please do not ignore it. It may not be a coronary, but it may be a dissecting aneurysm. That's the reason why pregnancy induces dissecting aneurysm is during pregnancy, structural changes do occur both in arteries as well as veins. And the structural change that occurs in pregnancy in the arteries is myxomatous degeneration of the media. That is partly reversible, but that is the basis why in the postpartum period that the dissecting aneurysms are not uncommon. So if a lady soon after delivery complains of pain in the interscapular region, consider the possibility of a dissecting aneurysm. Now, recently some data has come out. Some drugs like 4-aminoquinolines, when they are used for long term or more frequently, they're a bit more prone to develop dissecting aneurysm. It is something like usage of 4-aminoquinoline. I'm sure you must have heard of rupture of the Achilles tendon being more frequent. These drugs seem to interfere with the synthesis of collagen. So this failure of synthesis of collagen is responsible for making them more prone to develop a dissecting aneurysm of aorta. This is still a subject of being in evaluation, but keep that in mind. So take a drug history, whether the patient has been using any drugs long-term or more frequently. Can I have the next slide? Having said that dissecting aneurysms causes chest pain most of the time, it is important that dissecting aneurysms can also occur without pain, but it's very, very infrequent. In the international registry of aortic dissection, only 3.7% of the patients with dissection had no pain at all. This painless dissection is more common in the elderly, and that's the reason for delayed recognition, because there's no pain, you don't even suspect it. And because of delayed recognition, the mortality is also higher. So keep that in mind, that dissecting aneurysms can occur even without pain. Especially this will happen when you have asymmetry of the pulses, either in the lower limbs or in the upper limbs. Can I have the next slide? Now the third common or the second common symptom of a cardiac disease is the dyspnea. What do we mean by dyspnea? Dyspnea means awareness of difficulty in breathing. It's purely subjective, although objectively we see them having tachypnea, labored respiration, usage of accessory muscles of respiration. But by and large, dyspnea is a subjective symptoms. And the causes of dyspnea can be cardiac, it can be pulmonary, or it can even be systemic disorders like anemia, or even musculoskeletal disorders like skeletal myopathies. So these are all, there are various causes of dyspnea. How do we, commonly it is basically two major diseases are the cause of dyspnea. One is cardiac, other one is pulmonary. How do we distinguish by history? Now, if the pulmonary disease is the cause of dyspnea, usually there is some evidence of pulmonary disease by way of cough with expectoration, history of wheeze, seasonal variation, history of allergy, all these things are there. In the absence of that, the patient develops dyspnea for the first time without history of wheezing. Probably you should suspect a cardiac dyspnea. What is the mechanism of dyspnea? Dyspnea can be easily explained in patients with left heart failure. What happens is when there is a left heart failure, the pressure in the left ventricular diastole rises. Consequently, the pressure in the left atrium increases. And when the left atrial pressure increases beyond the oncotic pressure, oncotic pressure means that the osmotic pressure or oncotic pressure, or the pressure that keeps the fluid within the vessel lumen. And that is basically maintained by the plasma proteins. The normal oncotic pressure is about 25 to 30 millimeters of mercury. When the left atrial pressure increases to more than 30 millimeters of mercury, then the hydrostatic pressure, that is the pressure within the left atrium, increases over and above the oncotic pressure. That causes the fluid to be driven into the interstitial space. And that interstitial space is the lung. So that the interstitium of the lung is filled with water. So the lung becomes rigid. Once the lung becomes rigid, it takes more effort to expand the lung, a rigid lung, rather than a very, very compliant lung when there is only air and no fluid. And probably you can suspect that there is an ongoing what you call dyspnea or pulmonary edema, because initially there is only tachypnea. Even when you auscultate, there may not be any crepitations. For that matter, there may be some amount of wheeze may be there, which might lead you to think it may be bronchial. This wheeze is because of submucosal edema within the bronchi that causes narrowing of the lumen, and that causes the wheeze. So even before these crepitations appear, these crepitations appear only when the fluid spills over from the interstitial space into the alveoli. So crepitations is a very late phenomenon. So the first thing is patient with cardiac disease having tachypnea, suspect that he is an impending pulmonary edema. So the basis of dyspnea in patient with left heart failure is the hydrostatic pressure. This is what we call Starling's equation. That means when the hydrostatic pressure exceeds the oncotic pressure, the fluid goes into the interstitial space. So the basic mechanism is rise in the hydrostatic pressure, which is the pressure in the LA or in the pulmonary veins. Now, what about the other causes of dyspnea? Sometimes you do develop dyspnea even in patients with right heart failure. They say they can't walk, they get breathless. Patients with cyanosis also have decreased what do you call exercise capacity. So various other reasons are given. Any condition that causes a decrease in the cardiac output causing decreased flow of the blood to the muscles of respiration, or any condition that causes a decreased oxygen carrying capacity of the blood, like in cyanosis, it will also result in dyspnea. So by and large, dyspnea is a serious symptom, and important cause of dyspnea is cardiovascular diseases. Now, there are other varieties of dyspnea which have been described, and you should also know about it. One is paroxysmal nocturnal dyspnea. Other one is orthopnea. Fourth one is platypnea and trepopnea. And recently, one more pnea has been added, which is called bendopnea. Can we have the next slide? So what is orthopnea? Orthopnea is the patient becomes more breathless when the patient lies flat, and then he immediately gets up and sits up because he says he feels comfort and no discomfort and no difficulty in breathing. The reason is when you lie flat, there is shift of the blood from the lower limbs into the thorax. How much amount of blood is shifted? Approximately 500 ml of blood. So it is an auto transfusion of 500 ml of blood from the periphery to the intrathoracic area, and that raises the left atrial pressure, and that causes pulmonary venous congestion, and that causes the dyspnea. So the orthopnea indicates indirectly that the left atrial pressure is very high. and any further transfusion of the fluids or auto transfusion, like when you lie down flat, certainly will increase the hydrostatic pressure more and will make the patient more breathless. What is the other one is called paroxysmal nocturnal dyspnea. Unlike orthopnea, here a patient goes to bed comfortably, but then wakes up after about 4 or 5 hours in the middle of the night, saying that he's breathless. He gets up out of the bed, stands down, and then does some sort of a walking around the room, and then opens the windows classically because he feels that there is less amount of oxygen coming to him. And after some time, he goes back to bed comfortably. That the reason for this kind of this thing is this time lag represents the time taken for the interstitial fluid in the lower limbs that has come down into the vascular system, and then that will cause an increase in the venous volume, and that causes a rise in the left atrial pressure, and that causes the left atrial pressure increasing, causing venous congestion, pulmonary congestion, lung becomes more stiffer. So that is the reason why there is a time lag. Unlike orthopnea, nocturnal dyspnea, orthopnea is immediate shift of the blood from the lower limbs towards the thorax. Whereas in PND, the interstitial fluid has to be absorbed back from the interstitial spaces to the vascular system. So that takes hours. That is the reason why orthopnea is a much more serious rather than PNDs. But remember, orthopnea and PND indicates a serious left heart failure. Okay. Now there is one more condition called bendopnea, wherein there is when the patient bends forward for lasting for more than 30 seconds, he becomes breathless. But basically because again, there is increase in the preload because when you do bending, the abdominal compression, increase venous return. So all these all these things, orthopnea, PND, bendopnea, are all because of increase in preload at various points of time. Orthopnea is immediate, bendopnea is immediate, but PND takes 4 to 5 hours. Okay? Nocturnal cough is a very subtle sign of left heart failure because there the lungs are congested, so patient starts off by coughing. You should not mistake it as what we call postnasal discharge, which it can be, but consider the possibility of a incipient left heart failure. Can I have the next slide? So, what is the importance of dyspnea, orthopnea, PND, nocturnal cough? It not only says that there is a heart disease, but it tells you that the heart disease is because of left heart diseases. Any condition that is going to affect the left heart, mitral valve disease, left ventricular failure, aortic valve disease, or systemic hypertension. So paroxysmal nocturnal dyspnea, orthopnea, you should certainly evaluate and look for it because it not only tells you that the patient has got a heart disease, it also tells you that the pathology is in the left side of the heart and not on the right side of the heart. Can I have the next slide, please? Okay, not only like the what we call chest pain, you should also grade the type of dyspnea or the seriousness of the dyspnea. And we generally use NYHA classifications. Can I have the next slide? So there are other methods of grading the dyspnea apart from NYHA, what we call modified MRC. But in patients with pulmonary arterial hypertension, WHO has devised another grading of dyspnea or functional class limitations, wherein they have included syncope apart from dyspnea in grading the severity of the disease. And in case of children, there is another method called modified Ross classification of the severity of the functional impairment. Can I have the next slide? Okay, now unlike what we call orthopnea, there is one condition called PLATYPNEA orthodeoxia. Okay, this is exactly the reverse of orthopnea. In orthopnea, a patient is comfortable sitting up, and feels what you call discomfort when he lies down. In this PLATYPNEA orthodeoxia, patient is very comfortable lying down, but becomes symptomatic when the patient sits up. And if you measure the pulse oximetry, oxygen saturation when he's lying down is normal, but when he sits up, it falls. From about 94, 95, it falls to 85, 82. So this is exactly reverse of orthopnea. This condition is rather rare, but it has been described. So it is, if some patient says he's comfortable lying down, but then becomes more breathless when he sits up, think of the condition called PLATYPNEA. This is basically a right to left shunting, intracardiac or intrapulmonary, like pulmonary AV fistulas. And then they're comfortable lying down, and then they become symptomatic when they sit up. But the reason is because, can I have the next slide? But when the patient sits up, there is an alteration in the shape of the atrial septal defect communication, which is there most of the time. It changes its shape such a way that it facilitates the IVC flow into the left atrium, even in the absence of pulmonary arterial hypertension in that particular patient. It can be ASD, it can be PFO also. But this is a rare condition, PLATYPNEA orthodeoxia. But just keep it in mind that if the patient says comfortable lying, uncomfortable sitting, consider this. Can I have the next slide? Okay, so while we are the subject of what you call pain and dyspnea, one of the important symptoms, which is not often evaluated, is the claudication. When we talk about claudication, we often think of claudication only of the lower limbs because it's the most frequent, what they call LEAD, lower extremity arterial disease. Claudication coming on effort and relieved by rest is something similar to the coronary artery anginal pain. So claudication can be called as angina of the peripheral muscles. Unlike the cardiac muscle angina, this is angina of the peripheral skeletal muscles. Commonly, we say it is an atherosclerotic obstruction of the iliofemoral system or even lower end of the aorta at the bifurcation level extending into the iliac vessels. But remember, claudication can also occur in the upper limbs. Classically, in our country, we see Takayasu arteritis. But sometimes the claudication can occur even in the jaw, lower jaw. If the patient says that while masticating it, he gets the pain, when he's eating food and is masticating it, he gets the pain in the lower jaw. He has to stop for a while and then again start chewing. Think of temporal arteritis, which is not often thought of. So Takayasu arteritis in the upper limb, temporal arteritis for the jaw pain, they are often underestimated. Importance of remembering the claudication is not only that it points to the possible occlusive artery, like in a subclavian artery in a Takayasu, or a temporal artery in case of jaw pain, but in patient with lower limbs, if the claudication starts from the gluteal region, at the level of obstruction in the lower limb arteries is at the level of the iliac vessels. If it is in the thigh, it is femoral. If it is in the calf, it is a popliteal. So you should not only ask for the presence of the claudication, you should also ask where does the pain start and where does it go. Initially, it starts off from the distalmost region because that's the distal areas get the last drops of blood. So although it starts off it is maximal in the distal areas, but it starts off in the gluteal region, then the obstruction is in the iliofemoral vessels. So it not only gives you the presence of occlusive vascular disease, but it also tells you at what level is the occlusive vascular disease. This is very important. Suppose a patient has got atypical chest pain, or he has only what you call 2 out of the 3 components of the ischemia, and then if you find a patient has got a peripheral vascular disease, the probability of that patient having a coronary artery disease is extremely high because there is evidence of obstruction elsewhere. Most probably it is atherosclerotic. And in case of young patients, it can be Takayasu arthritis, it can be temporal arthritis. Not to forget about prothrombotic conditions like APLA syndrome, antiphospholipid antibody syndromes. So finally, you should not only remember whether there is claudication or not, we should also know, like in angina, at the rate of progression of the angina, of the claudication. If there is a rapid progression of claudication, coupled with elevated inflammatory markers in the blood, it points out the presence of inflammatory or aortoarteritis or arteritis of any etiology. Remember, this temporal arteritis is called giant cell arteritis. It can not only affect the temporal vessels, it can also affect the iliofemoral vessels. So if there's a rapid progression of symptoms, the positive inflammatory markers in the blood, think of the possibility of an arteritis as the cause rather than atherosclerotic. Agreed that atherosclerotic occlusion can also have rapid progression because of subintimal hemorrhage or a superadded thrombus. But this is one of the things to be covered. But in those patients, there is no rise in the inflammatory markers, unlike in arteritis. Can I have the next slide? Okay, the third symptom of cardiovascular diseases is the palpitation. It's a very common complaint, but then we should take some time to ask what exactly the patient means by saying palpitation. Is he aware of the rapid heart action all the time, even at rest and other things? Or is the rapid heart action occurring in paroxysms? If he is aware of only of the heart action, is different from aware of rapid heart action. Aware of the heart action means there is volume overloaded ventricles. It can be mitral regurgitation, it can be aortic regurgitation, it can be severe tricuspid regurgitation. So you should make a clear distinction when you say palpitation. Are you aware of the heart action, or is your heart beating rapidly? If the heart is beating rapidly, you can ask the fellow to tap it on the table and then tell us how fast it is beating. Not only how fast it is beating, is it regular or irregular? He says sometimes it skips. So first and foremost is when the patient says palpitation, he is aware of the heartbeat, or is there a rapid heart action? Now, as I said, if there's a rapid heart action, that means there is, especially if it is occurring paroxysms, then it is probably dysrhythmias caused by arrhythmias. So if it is arrhythmias, you should ask, what is the onset? Sudden onset, gradual onset. How long it is lasting? 5 minutes, 1 hour, 2 hours. During the episodes of this rapid heart action, are there any associated symptoms? Like feeling giddy, or becoming very breathless, or feeling of even blackout during that time. It is generally believed that ventricular tachyarrhythmias, especially in the setting of a structural heart disease, is very more symptomatic than supraventricular tachycardias occurring in an otherwise structurally normal heart. That the reason is that in ventricular tachycardias or ventricular tachyarrhythmias, there is loss of atrial kick. Atrium contraction contributes almost about 10 to 15% of the left ventricular filling. So suddenly if you lose the atrial contribution to the ventricular filling, more so in a patient who has got a structurally abnormal heart like a left ventricular hypertrophy, then there will be a steep fall in the left ventricular input, consequently the output. So he is likely to become more symptomatic by way of giddiness or even syncope. So it is important that you go to it, how often it happens, and what is the clinical status of the patient during tachyarrhythmias. And are there any drugs which the patient is taking which can cause potential arrhythmias? Don't forget, there are some drugs which can cause prolongation of the QTC and then cause ventricular tachyarrhythmias. that the prokinetic drugs given by the gastroenterologists are all prokinetic. That the present day COVID era, the combination of azithromycin and other things can also cause prolongation of the QT, and polymorphic VTs are not uncommon. So it is important that whenever a patient has a palpitation, is he aware of the heart action, or is there any proximal rapid heart action? Is he taking any drugs which can potentially cause this palpitation? Is it symptomatic during tachycardia or not symptomatic? All these things will give you a lot of insight for the possible cause. Can I have the next slide, please? Syncope. This is a very important symptoms, and most of the time when a patient has syncope, he invariably comes to this just to see the doctor without anybody asking him to go to see a doctor. And quite often that they end up with the wrong specialist. They often tend to go to the neurologist because they feel that basically there is something wrong with the neurological system. They are right to some extent when they say neurologist, because syncope is due to global reduction of the blood flow to the brain. Mark the word global reduction. That is basically because there's a marked sudden decrease in the cardiac output for whatever reason. We'll come to that. But when somebody says syncope, history plays a very, very important part in the evaluation of the patient. Is the syncope occurring at rest or on effort? This is very important. Or is it occurring what we call situational syncope? Is he getting syncope during the prolonged cough? Is he getting syncope during micturition? Is he getting syncope during deglutition? So on and so forth. So it is important that you take history properly. Or is he getting syncope on prolonged standing? Like in school, some of the school drills where they make you stand for about 1 hour during the process of drill. So asking the details of that is important. Exertional syncope, if it is present, is a very ominous sign of a cardiovascular disease. It is important to know about this because exertional syncope is synonymous with LV outflow tract obstruction like aortic stenosis or even hypertrophic obstructive cardiomyopathy. It can also occur even in right ventricular outflow tract obstruction like severe pulmonary arterial hypertension. But common to both is a steep decrease in the cardiac output during the effort. So why does that happen? Because of obstruction, the need to have an increased cardiac output cannot take place because of severe obstruction in case of severe aortic stenosis or hypertrophic obstructive cardiomyopathy. Coupled with an inadequate cardiac output, there is inappropriate vasodilatation. Why does it occur, inappropriate vasodilatation? Because there is stimulation of the mechanoreceptors within the endocardium of the ventricle. So this decreased or inadequate cardiac output coupled with inappropriate vasodilatation causes a marked decrease in the cerebral perfusion, which causes syncope. So this syncope, by and large, is usually, at least in majority of the people, is associated with premonitory symptoms. On the contrary, if the patient says he is getting syncope while sitting, then you need to suspect that the patient is having probably arrhythmias. Syncope at rest without premonitory symptoms is an arrhythmic event, especially in the background of an established cardiac disease. For example, a patient has got a cardiomyopathy on decongestive therapy, and then the parents or some of the attendants bring the patient saying that he was sitting in the chair and then suddenly fell off. That means the patient probably has got a major ventricular tachyarrhythmia. Although other causes are possible, but this is one of the most dangerous things because it can lead to sudden cardiac death. So basically, you need to evaluate syncope a bit more detail. That is, What is the history of, is it occurring at rest or on effort? If it's occurring at rest, what is the position of the patient, sitting, standing, or lying? And what are the situations during which the syncope occur? What do you call coughing or micturition, or any such situation, like including deglutition? So that will give you a better answer than any other investigations which you may like to pursue subsequently. Can I have the next slide? Pre-syncope is a word that has been used more, not only, mostly by the doctors. And according to the ESC guidelines, what is pre-syncope? Pre-syncope is occurrence of premonitory symptoms like lightheadedness, graying of vision, nausea, uneasiness in the chest before the syncope. So pre-syncope is premonitory symptoms without loss of consciousness is pre-syncope. But its what you call diagnostic value is rather limited. It's a non-specific thing. So we should not give so much of what you call importance in evaluation of pre-syncope. Can I have the next slide? Okay, finally, edema of the lower extremities, especially dependent, is quite often a sign of a right heart failure. It is a consequence of increased systemic venous pressure. Same thing is applicable here, like the Starling's law. Hydrostatic pressure exceeding the oncotic pressure. So there is fluid leakage into the interstitial space, and that's what we are calling as edema. So cardiac edema is a pitting edema, is a non-tender edema. It is bilateral. It is very slow in onset and probably responds very well to the diuretic therapy. If it is a late evening edema of the feet, patient says he is okay in the morning, but then late evening, 8 o'clock he gets edema of the feet, then there are only two conditions. Either it is related to the venous insufficiency, chronic venous insufficiency, or related to long-term usage of calcium diet, repetitive group of drugs. The worst offender is the nifedipine. Whatever it is, if the edema is not there in the morning hours and appearing only in the later part of the day, suspect chronic venous insufficiency and also take the drug history. What are the drugs the patient is taking? Now, ascites, that is fluid in the peritoneal cavity, is also a manifestation of right heart failure. But there are very few conditions. Ascites is not as frequent as the dependent edema. Occasionally, ascites even precedes the dependent edema. There's only one condition like that. That is what we call ascites precox. Ascites preceding the edema of the feet. And quite often it is mistaken for cirrhosis of the liver. So ascites preceding the edema of the feet is equivalent to constrictive pericarditis. That is a rule, unless proved otherwise. There are other reasons, but consider as if the patient says his abdominal girth is increasing for the last 6 months only. Now he has developed edema of the feet. It can still be cirrhosis of the liver with ascites, but there is also a possibility of what we call constrictive pericarditis. So it is said that in all patients with cirrhosis of the liver with ascites, you should always look at the jugular venous pressure. Cirrhosis of the liver will never have elevated jugular venous pressure. If the jugular venous pressure is elevated in a patient with cirrhosis of the liver, it is constrictive pericarditis or a restrictive cardiomyopathy until proved otherwise. There are other reasons, but by and large, these are all the rules of thumb. So ascites, you should look for it, and ascites indicates usually a serious right-sided disease, especially tricuspid valve disease. Can I have the next slide? Okay, cyanosis is the last symptom actually. What do you mean by cyanosis? It's a bluish discoloration of the skin and mucous membranes. Where does the color really come from? It is a reflection of the color of the blood in the capillaries. And that blood becomes blue only when the reduced hemoglobin is more than 5 grams per deciliter. Okay? So, normally when there is cyanosis, the arterial oxygen saturation is less than 85%. You put a pulse oximeter in a patient who is cyanosed, the arterial saturation will be less than 85%. Now, there are two caveats here. One is in conditions of anemia and in conditions of polycythemia. In anemia, there may be severe desaturation, but yet there may not be cyanosis because hemoglobin itself is 7 grams. And even if you decrease the, reduced hemoglobin by 50%, the reduced hemoglobin will be only 3.5 grams. So in the presence of anemia, cyanosis can be very misleading. It does not occur even though there is serious desaturations. On the contrary, in polycythemia, where the hemoglobin is very, very high, like 20 grams per deciliter, even if there is a fall of the hemoglobin to 90%, there will be marked cyanosis because there 10% fall in the oxygen saturation will result in more than 5 grams out of 20 grams. So with these two caveats, by and large, assuming that the hemoglobin level is normal, which is about 13 to 15 grams per deciliter, cyanosis means the saturation is less than 85% and the amount of reduced hemoglobin is more than 5 grams per deciliter. Can I have the next slide? Okay, cyanosis is often defined as whether it is central cyanosis or peripheral cyanosis. Quite often, people misunderstand the central and peripheral cyanosis does not, mark the word does not, refer to the distribution of cyanosis. It refers to the mechanism of cyanosis. In central cyanosis, there is intracardiac or intrapulmonary right to left shunting. Whereas in peripheral cyanosis, there is increased extraction of oxygen. Because of decreased cardiac output, there is increased extraction of oxygen by the tissues. That increases the reduced hemoglobin to more than 5 grams. And that is the cause for appearance of cyanosis. So cyanosis is central and peripheral, refers to the mechanism of cyanosis, not to the distribution of cyanosis. Having said that, subtle cyanosis, usually the limbs are very warm, and in peripheral cyanosis, usually the limbs are cold. And basically because there is decreased cardiac output in peripheral cyanosis. Okay, so remember that central cyanosis, you look at the conjunctiva, look at the mucous membrane of the mouth and the tongue, and the nails beds, assuming that the limbs are quite warm. Okay, can I have the next slide? So, although cardiac disease presents with a lot of symptoms referable to the cardiovascular system, occasionally these symptoms can be referred to the other systems like respiratory system or neurological symptoms, especially cardioembolic strokes. So all patients with stroke suspect there may be a cardiogenic cause of stroke. That's very important. Pyrexia of unknown origin can be a manifestation of infective endocarditis, native valve or a prosthetic valve. So it is important that you keep it in mind that it can manifest with symptoms referred to other systems. Can I have the next slide? So now, having evaluated all these symptoms, finally, you want to know whether it is interfering with his lifestyle, whether it is interfering with his ordinary physical activities. So the functional disability consequent to the symptoms is important. So if the CV disorders are severe enough as to interfere with the normal activities or ordinary physical activities, that means the disease is pretty severe. And there's a major indication for treatment. not necessarily surgery or angioplasties or some other non-surgical procedures, but it is an indication for starting of therapy. So the presence of a serious symptoms not only indicate the presence of disease, but also the seriousness of the disease. But then how do we evaluate the functional disabilities? Can I have the next slide? Okay, you just skip this slide. Next one. Next one. Yeah, okay. So how do we evaluate the functional capacity, or what do you call functional disabilities? There is an objective way of doing it called Duke Activity Status Index. You forget about all those things. Just remember, you need to ask a patient 4 questions. Can he do self-care activities? That means, can he dress, undress? Can he shave? Can he do the brushing? Can he take bath on his own? That is called self-care activities. Can you do household activities? That means, can you walk indoors? Can you do dusting or dishwashing in case of females or otherwise? Or can you climb 1 flight of stairs? Then recreational activities, gardening, running for short distance, playing with your kids and other things. Those are recreational activities. Finally, does he play any games? Does he play any, what do you call, vigorous games or not? All this one will give you some idea, objective idea about his functional capacity. Functional capacity, scientifically speaking, has to be expressed in terms of METs. MET means metabolic equivalent. Each metabolic equivalent is equal to 3.5 ml per kg per minute is the oxygen consumed. That means at rest, we are having only 1 MET of work. That means no activity, just lying down in the bed. So if you're a 70 kg man, you're consuming 70 into 3.5 ml of oxygen. That is about 210 plus 30, about 240, 250 ml of oxygen per minute. Any further activity is expressed as multiples of METs. For example, self-care activities is 2.75 meters METs to 3 METs. That the most demanding self-care activity, which requires more oxygen consumption, is taking a bath by himself, which costs about 3 METs of work. Okay, so if the patient is able to take care of or take bath without having chest pain, without having dyspnea, without having palpitations, that means he is okay. At least he is not very severe. Now, if he's able to do self-care activities but not able to do household activities, that is what we call class 3. So class 3 means serious disease, and that calls for urgent investigations and treatment. Recreational activities class 2, sporting activities is class 1. So you need to ask the patient these questions. Can you do self-care activities? Is he comfortable? Can you do ordinary household activities? Yes. Then recreational activities. Then probably it will give you some idea that what is the level of functional disability. Can I have the last slide, please? So for all the people who are listening to me, see, the symptoms evaluation is very important, which I've alluded to already. It will tell you the presence of disease. It will tell you the severity of the disease. It will tell you the progression of the disease. So symptoms are very, very important. And some of these symptoms point to a specific disease. For example, presence of PND, orthopnea, almost always indicate a left heart disease. Just as effort syncope indicates left ventricular outflow tract obstruction like aortic stenosis or hypertrophic cardiomyopathy. Awareness of the heart beating, but not rapid heart beating, indicates cardiomegaly, usually due to a volume overloaded ventricles. Okay, and then the amount of functional disability that patient has, dictates the timing of investigations and interventions. And finally, evaluation of the symptoms after therapy also indicates whether the therapy has been successful or otherwise. Thank you, ladies and gentlemen, for your attention. I'll take on any questions if you have any. Shantanu.
Good evening, sir. Sudhakar here, sir.
Yeah.
Sudhakar here, sir.
Yeah, tell me. Yeah.
I'll pass on the question, sir.
Yeah.
Mechanisms of dyspnea in isolated right heart failure.
That's what I have said already. That is basically because the skeletal muscle gets exhausted because of low cardiac output.
Yeah. Also, the orthopnea mechanism in like right heart failure, few diseases which cause orthopnea in right heart.
Orthopnea is certainly a case. Orthopnea, if you really take the, orthopnea has to be evaluated properly. But if you are convinced that the patient has got orthopnea, then it is a sign of a left heart disease. Orthopnea and PND. These two are very specific. Although there are other diseases. For example, there are what do you call ENT diseases which can cause orthopneas. But that should not be mistaken. But by and large, if you say patient has got dyspnea on exertion and he has orthopnea and PND, he has got a cardiac disease, and you need to focus your investigations and examination to the left side of the heart. Whether he has any left atrial, mitral wall, left ventricle, aortic wall, aorta, all those things we need to be evaluated. By and large, that is the same. Now, there are some situations like patients having constrictive pericarditis. The huge ascites, when they lie down flat, they are restless, they are not very comfortable. That should not be interpreted as orthopnea. He should wake up, he should get up with breathlessness, not because of uncomfortableness. So there are situations wherein there are massive, what you call ascites or severe hepatomegaly consequent to right heart failure. That will also make them uncomfortable when they really lie down. But that should not be equated with orthopnea.
Okay, sir. Can you please explain the syncope in AS again, sir? Like different mechanisms of syncope in AS.
Yeah, syncope is basically because of global hypoperfusion of the brain. It is not due to a isolated carotid artery stenosis or a bilateral carotid artery stenosis. It is globally there is decrease in the perfusion of the brain. And the syncope is what we call, you have to ask whether syncope is occurring at rest or on effort. I'll explain to you why they have what we call effort syncope in hypertrophic cardiomyopathy and aortic stenosis, valvular aortic stenosis. So what happens in valvular aortic stenosis is because of severe aortic stenosis, patient is not able to increase the amount of cardiac output proportional to the exercise. What is the proportion is for every 100 ml increase in oxygen consumption by the body, the heart has to increase its output by about 600 ml per minute. Now, if that is not able to improve its cardiac output, then it becomes an inadequate cardiac output. And this inadequate cardiac output in response to exercise, coupled with inappropriate vasodilatation of the periphery, consequent to stimulation of the mechanoreceptors within the endocardium of the ventricle. So the combination of low output coupled with inappropriate vasodilatation that causes most of the blood to go away from the brain to these working muscles. And that is the reason why the brain gets less blood, and that's the reason why they have syncope. Now, the syncope at rest is due to, most of the time, as I said, is due to the arrhythmias. Sometimes you also get what we call vasovagal attack. It's a reflex syncope. I will not go into the details of syncope, but situational syncope is also like that. This cough syncope is because of continuous cough, there is a decrease in the venous return to the heart because of raised intrathoracic pressure. So decreased venous return really results in decreased output of the left ventricle, which results in decreased perfusion to the brain and consequently loss of consciousness, what we are calling it as syncope. So these are all basically fundamental to the syncope is global hypoperfusion. Mechanism of syncope in pulmonary embolism, I just saw it. It is a manifestation of major severe obstruction, sudden severe decrease in cardiac output. They have syncope. That syncope in pulmonary embolism is a very bad sign. They got a very poor prognosis. I've seen patients where they can, what do you call CT angio proved massive pulmonary saddle embolism sitting in the pulmonary, main pulmonary artery, right pulmonary artery, left pulmonary artery. They rarely survive, but they do survive if you recognize them early and give them appropriate thrombolytic therapy or even embolectomy. So basic to the syncope in pulmonary embolism is marked decrease in sudden severe decrease in cardiac output.
There is a question on what is the mechanism of ascites precox, like you.
Ascites precox, nobody has explained till today, but it does occur.
Then other mechanisms of PND apart from the important one you told, sir.
Other mechanisms?
PND, sir.
PND, what I said, no, other reasons. I have given only hemodynamic mechanism of the PND. Other reasons have been given in the sense that there are abnormal stimulation of J receptors, which causes abrupt cessation of the inspiration consequent to head-immune reflex. There are other, inappropriate response to the respiratory center. But by and large, only the hemodynamic mechanism is the most accepted and most definitive one.
Why nocturnal angina in syphilis, sir? Like that?
Actually, there is in syphilis. Actually, there is aortic regurgitation as well as narrowing of the osteo of the coronary arteries. I guess mostly what we call it is this aortic regurgitation that becomes worse during nighttime, as I alluded to. During nighttime, there is bradycardia, relative bradycardia. So the duration of diastole becomes longer, and consequently the aortic regurgitation becomes more and more in magnitude, and consequently more distension of the LV, and consequently more demand for oxygen as a result of Laplace's law. Wall stress increases, so more demand for oxygen, which cannot be met by the stenosed coronary arteries, nocturnal angina.
Is there any specific mechanism for Pathophysiological, sir? Like,
sorry?
Pathophysiological.
Pathophysiological is dyspnea on lying down to one side. Pathophysiological. This is usually happens when you lie opposite to the pleural effusion site, because the other side also can't expand and the normal side also can't expand. Although they are all described, how often have you seen Pathophysiological and PLATYPNEA?
Not very common, sir.
Yeah, it's not very common. It has to be very massive, and patient has to be very sensitive. Usually, you lie down on the same side as the deceased side, because at least the normal side is working. Suppose assuming that the pleural effusion is massive on the right side, and then you lie down on the left side, and then you have both sides not working. That causes more distress. Pathophysiological is, by definition, is dyspnea on lying. It's only what you call decubitus dyspnea, lying to one side causing dyspnea.
How much weight is be given to the anginal equivalents?
Sorry, what was the question?
Anginal equivalents, like.
What do you mean by anginal equivalents? Actually,
yes, sir.
Actually, you see, the problem is you need to understand what we call ischemic cascade. When you cause decrease in the coronary blood flow, abrupt decrease in the coronary blood flow, whatever may be the mechanism, or abrupt increase in the demand for oxygen, the cardiac muscle becomes ischemic. So what happens in the ischemic cascade is the first change that occurs is the biochemical change within the cardiac muscle, followed by mechanical abnormalities. First, initially diastolic dysfunction, followed by systolic dysfunction, then followed by electrical changes by way of ST segment deviations, finally followed by symptom of angina. So basically, when we say anginal equivalence, we mean equivalence of ischemia other than chest pain. So equivalence of ischemia other than chest pain are the dyspnea, flash pulmonary edemas. And basically we say sometimes you do develop syncope on effort. Syncope on effort is a very bad, sign or even a symptom of coronary artery disease. That can be due to because there is so much area of the muscle is dysfunctional because of ischemia. Let us say it is severe LMCA disease. Then you have the whole 90% of your LV myocardium is ischemic, and suddenly you get into serious difficulties and cardiac output falls, or sometimes even precipitation of arrhythmias, which might cause symptoms. So anginal equivalence by definition is ischemic manifestations of LV of the cardiac muscle other than pain. When we say silent ischemia, it is totally different.
I have a question, sir. Does this bendopnea point to a specific group of diseases? Like, though not actually. Like
Bendopnea has been described only in the 90s. That is when when the patient is bending forward to tie his boot laces, he is getting dyspnea, and that has been equated with hemodynamic profile of what we call type C profile, where type C hemodynamic profile is elevated filling pressures and decreased cardiac output. So there is basically they are on the borderline of dysfunction, which is aggravated by bending forward, consequently causing abdominal compression, increase in the preload. And that is the cause of his worsening of the symptoms. He is not totally asymptomatic otherwise. He is symptomatic, under control with drug therapy, and then becomes worse whenever he bends.
Is one question on what will be the saturation of oxygen when dyspnea starts manifesting. I didn't understand this question.
When dyspnea starts in which condition?
Manifestation. When dyspnea starts manifesting.
Manifesting, okay. Actually, first thing that happens is the tachypnea. Tachypnea is basically because it cannot take a deep breath. It is inspiration is interrupted. So in order to compensate for the loss of depth of the inspiration, it increases the rate. Basically because the rate increases, basically because that the lung becomes more rigid. So the saturation will start to fall probably about 90, 95 downwards. And then by the time they develop frank pulmonary edema, it may go as low as 85, 86. And the fall in the saturation in pulmonary edema is basically because of ventilation perfusion mismatch, because it can be corrected by giving oxygen. It is not due to a diffusion problem. It is basically a ventilation perfusion mismatch that causes this, fall in saturation and dyspnea.
There is one last question, sir. Can we be specific based on symptom, whether it is purely right heart failure or left heart failure?
No. Symptoms, clinical medicine has got its own limitations. I think all of us need to understand that no matter how good you are as a clinician, your ability to pinpoint the diagnosis to be very accurate, at best is 60%, 70%. It cannot be more than that. And to differentiate between right heart failure from the left heart failure is possible, but remember that the commonest cause of a right heart failure is left heart failure. So whenever there is a right heart failure, we need to see whether whether there's any underlying left heart failure. In the absence of left heart failure, the right heart failure can be due to cardiopulmonary, pulmonary embolism, a lot of other conditions. primarily right ventricular diseases, including right ventricular cardiomyopathies, right ventricular restrictive cardiomyopathies. But by and large, we do, the symptoms, as I said, PND and orthopnea is probably indicates that it is left heart disease, at least to start off. Further, if you find elevated jugular venous pressure, edema of the feet, enlarged tender liver, ascites, then it is a sign of a right heart failure. With the full understanding, for example, you take mitral stenosis. Mitral stenosis, we have some signs and symptoms of left heart disease, and ultimately, when they do develop pulmonary hypertension with tricuspid regurgitation, they have all the right heart failure. That is a classical example of a left heart disease leading to right heart failure. So, isolated right heart failure in the absence of left heart failure that is a separate syndrome. So, that is the reason why we say that you should start off by evaluating the left heart disease in patient with right heart failure and then proceed.
Can I take one last question before?
Sure, sure.
The mechanism of Cheyne-Stokes respiration in LV failure, sir.
Cheyne-Stokes respiration, actually, it is, I'm not very sure, but you read the physiology book, textbook of physiology by Best and Taylor.
Okay, sir. I think we'll conclude here. I think most of the questions have been taken care of.
Yeah. Okay.
Mr. Santanu.
Yes, sir. We are now towards concluding this wonderful program. I must say it was an exciting program which has enabled us to gain from the wisdom and expertise of the speakers and panelists. I take this opportunity to thank Dr. Dayasagar Rao and also Dr. Sudhakar Rao for their great contribution in making this program possible and successful. I am thankful to all participants who have taken time out of their busy schedule to attend this program. I thank all of you for making this event successful, and I sincerely hope your support will remain with Taurine in times to come. Thank you, goodbye, and good night to all, sir. Sir, thank you very much, Dr. Rao.
Thank you, Shantanu. Thank you, Sudhakar.
Thank you,
Sudhakar, for it.
Thank you,
How many people logged in? Any idea?
Sir, around 175, sir.
175. Okay. Fine.
And thank you very much, sir. It is a great contribution.